You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for November 21st, 2025. This week, we'll do a little bit more listener feedback. There's huge news in the world of carotid vascular disease with publication of the CREST-2 trial this morning. Prasugrel and ticagrelor are added again, and a big coffee trial. Now, the first order of business today is that next weekend is Thanksgiving, so This Week in Cardiology takes a week off, and I'll be back on December 5th. All right, listener feedback. I continue to receive pushback on my view of the complete versus culprit-only debate during STEMI. I contend that the most recent, highly non-significant full revas trial likely represents the truth, namely that the other coronary disease that's not involved in the occlusion represents stable disease and that PCI of stable disease does not reduce future serious outcomes over medical therapy. My argument is that if PCI of the non-culprit lesion improved outcomes, then that would go against decades of evidence that PCI of stable CAD does not improve outcomes over medical therapy. Now, of course, I bolster my argument by citing the fact that the complete trial was positive only because of non-fatal MI reduction. This was not enough to improve CV death. And, of course, incomplete peri-procedural MI events could not be counted. That's because there's a huge troponin rise with the initial STEMI. The PREMI trial was also a positive trial for complete over culprit only, but the benefit was driven here by less refractory angina, but the trial was unblinded. So, of course, there's going to be more angina when people know there is an unfixed lesion. Now, sadly, the full REVASC trial was terminated when the complete results came out, as if to say it was unethical to continue to do culprit-only PCI. Then, when they open the data of full REVASC, they find similar numbers of events in each of the two groups. So this week, I received another note from Dr. Paul Brady from Gloucestershire Hospital in the UK. Paul makes two arguments. A, non-culprit CAD during a STEMI is not the same as CAD like that in Courage or Berry 2D. In other words, it's higher risk. He writes that we know from studies such as the Global Registry of Acute Coronary Events, the GRACE registry, that patients who present with ACS have a higher risk of future events than patients with chronic stable angina. ACS can trigger systemic inflammation, which puts the particular patient group at high risk. And he goes on to say, while this risk reduction is driven primarily by reducing the risk of recurrent MI rather than mortality, from a patient perspective, this is important because when Dr. Brady talks to patients who have had an MI and I tell them I can offer them a second procedure, which may not impact their mortality risk, but will reduce the risk of a recurrent MI by about 25%, most of my patients are very keen to have this treatment. So I thank Dr. Brady for listening and taking the effort to respond because, first of all, I looked up Gloucestershire and it looks like a beautiful place there on the west coast of England. Second, I get that patients with ACS may be higher risk, but my question is not risk, but whether intervening improves on outcomes over medical therapy. Maybe it does, but gosh, the way I see the data, it is more consistent with Courage, Ischemia, and Berry 2D. Now, Dr. Brady did not cite a meta-analysis from the McMaster's team that was published in The Lancet on November 9th, just a few weeks ago, and this was 6 trials of complete versus culprit only. I just want to address it fairly quickly because you may have seen this meta-analysis. And this was a patient-level meta-analysis of 6 trials looking at culprit only versus complete revascularization. The first author is Shamir Mehta. The trial had 9,000 patients in these 6 trials. The primary question was complete versus culprit-only STEMI. Now, the group who did the meta-analysis actually calls themselves, quote, the Complete Revascularization Trialist Collaboration, which is sort of like having a Watchman trialist collaboration. I will give you the main findings. Since the paper comes from the complete revascularization trialist collaboration, you can probably guess the results. Because you don't think the complete revascularization trialist collaboration would report that complete revascularization was ineffective, do you? No, they would not. And of course, that's not what they found. CV death or new MI as a component was 24% better with complete revascularization. CV death alone was 24% lower with complete revascularization. All-cause death was even better, 15% lower. And non-cardiovascular deaths were similar. Complete revascularization also reduced new MIs compared with culprit-only PCI. And here the hazard ratio is 0.76. Almost everything is 0.76, 24% better. So it's all positive. But there are nuances. First, this meta-analysis included non-STEMI trials. Here, about 12% of patients. That's bad, because non-STEMI cannot count in this question, mainly because during non-STEMI, it's hard to sort out the culprit lesion, so if you do complete revascularization, you're likely to get the culprit lesion. For instance, the FIRE trial included non-STEMI, and it appeared to be the driver of the outcomes in this meta-analysis. Now, I use the phrase appeared to be because the authors did not seem to do, I didn't see it, a sensitivity analysis where they do the analysis minus a trial. You do the meta-analysis minus one trial, then another trial, then another trial, and this way you figure out which trials, if any, are driving the results. This way they could prove which study drove the results, and it's weird because this seems like a basic thing in meta-analysis, and I would have expected at least to see it in the supplement, but I didn't see it. Overall, I'm still not persuaded by this meta-analysis because the two drivers of the positive study are the complete trial, which of course did not have a CV death reduction and could not count peri-procedural MIs, and the FIRE trial, which included non-STEMIs. So overall, I still don't believe that routine non-culprit PCI to get close to complete revascularization is any better than culprit-only PCI at the time of a STEMI. The data are not convincing, and they comport with Bayesian priors that say that non-occlusion-related lesions should be stable. Now, this does not mean that clinical judgment needs to be usurped by trial evidence. You must always consider that trials do not include consecutive patients. Instead, trials include patients that the doctor feels are randomizable. Many patients don't get in the trial because the doctor used judgment and felt that A, the patient should have a non-culprit PCI, or B, this patient should definitely not have a PCI, and so those patients don't get included in the trial. Randomized controlled trials give us an average effect of those chosen to be randomized. This evidence should not be generalized to every single patient. There are, of course, exceptions. That said, however, the onus of proof is on those who propose to do more rather than less, especially in the setting of PCI. So show us, if you think this patient would benefit, that's a patient we should do further studies on. Now, a second email I received addressed the issue of class effect versus specific agents regarding MI, the MI story. For example, bisoprolol is a beta-1 selective beta blocker, and it was one of the beta blocker used in the negative post-MI beta trials. So this writer who wrote to me questions, quote, why do people prescribe drugs not shown to be effective in preference to those that have been? Why is bisoprolol used at all post-MI in the absence of evidence? Why is ramipril most widely used ACE inhibitor in HFrEF when only enalapril is shown effective? And I have to say, my response to this is it's a hard question. I really think about it and I wonder about it. Consider the story of bucindolol. Bucindolol is a non-selective beta blocker. It's a mild vasodilator. It's similar to carvedilol. It's not indicated in HFrEF because of the BEST trial. Now, the BEST trial ran concurrently with the carvedilol trials, and BEST did not find a statistically significant lower mortality. So, bucindolol is not used. But was it the drug bucindolol or was the patients randomized? So when you go look at BEST, it was 30 versus 33% overall mortality. Super high mortality. That's versus 7 and 11% in the MERIT trial, which was metoprolol XL. It's highly likely, in my opinion, that bucindolol failed because patients were most fragile and susceptible to the negative inotropic effects. Andrew Foy and Mohamed Rouzier and I discussed this on our Cardiology Trials Substack. My point is that I don't know about specific drugs versus class effects. It's hard for me to believe that beta selectivity is the reason that the newer beta blocker trials failed. Rather, it seems to me it's the nature of MI, but maybe I'm wrong. It's also hard for me to believe, say, in heart failure therapy, for instance, that metoprolol tartrate is much different than metoprolol succinate. I really don't know. And so I'm interested in your feedback and to think about this, but it's a good question. Now, a third listener feedback I got was one from Dr. Ben Costello in Melbourne, Australia, and he addressed my coverage of the Vesalius trial of evolocumab. Ben wanted to push back on the language describing lipids as a causal factor in atherosclerosis, and he writes, quote, "While there's no doubt that cholesterol plays a central role in the pathogenesis, framing it as purely causal can imply inevitability. That means that high cholesterol always leads to atherosclerosis. We know there are individuals, including those with heterozygous familial hypercholesterolemia, who reach their 60s without ever having evidence of atherosclerosis, which suggests that while cholesterol is indeed involved, there likely needs to be a driver, such as inflammation, whether it's triggered by diabetes or insulin resistance or hypertension or smoking or other inflammatory conditions that influences the actual development of atherosclerosis." Dr. Costello's second point addressed going beyond relative risk reduction. He favored highlighting that the evolocumab trial, like many other primary and secondary prevention trials, shows about a 2-year delay in events for those who would eventually have them. This kind of absolute measure that he likens to progression-free survival in oncology gives a clearer picture that for most patients, the therapy essentially buys time rather than just reducing a percentage risk in the abstract, and that the majority of patients have no event at all. He also noted that the trial underscores the benefits of targeting therapy to the right group of people, noting that in Australia currently, the PCSK9 inhibitor drugs are limited to patients with FH or a prior event, but this new trial shows that this strategy likely misses a big group of patients with high atherosclerotic burden that could be helped. So as always, I appreciate these comments. They're really good, and I'm getting more and more of them, so thank you. All right, the next topic, and it's a big topic. This is big. This is a sea change in the treatment of carotid artery disease. The CREST-2 study is published. It was published at 10:30 a.m. this morning. This podcast comes out later. We learned the results, and New England Journal of Medicine published the results. This is asymptomatic carotid artery disease. Now, it's a huge deal because the approach to these patients varies based on geography. Some geographies, some systems, like here in the U.S., do a ton of revascularization in patients with asymptomatic disease. You know, somebody gets an ultrasound, there's an 80% lesion. Many of these patients get operated in the U.S., whereas in other countries, they're treated medically and not operated on. There were 2 recent trials, SPACE-2 and the ECS-2 trial, which I'll link to. They've failed to show any benefit to revascularization over medical therapy in patients with asymptomatic disease. In addition, the parallels to chronic coronary disease are here. Only in the brain, right, there is even better protection against total occlusion, that is the circle of Willis. Now, CREST-2 trial began a decade ago, and it had 2 randomized parallel groups of about 1,200 patients each who had asymptomatic carotid lesions greater than 70%. One group was carotid artery stenting plus medical therapy versus best medical therapy alone. And the second parallel group of 1,200 patients were split carotid endarterectomy plus medical therapy versus medical therapy alone. And the primary endpoint was an interesting one. It was a composite. It was a 4-year composite of any stroke, hemorrhagic or ischemic, or death in the first 44 days after the procedure, or an ipsilateral stroke during the remaining 4 years of follow-up. So the results. In the stenting trial, the rate of the primary endpoint was lower in the stenting arm. 2.5 versus 6.0% with an absolute risk reduction of 3.2%, but a p-value that reached only 0.02. We'll talk more about that. Now, the breakdown of the two components of this endpoint goes like this. In the first 44 days, there were 0 events in the medical therapy arm, of course, because they weren't operated on, didn't have a stent. But there were 7 strokes and 1 death in the carotid stent arm. So that's 0% versus 1.3% in that first component. But in the follow-up period, beyond 44 days, there were 28 patients who had ipsilateral stroke in the medical therapy arm versus only 7 in the carotid stent arm. So that's 1.7% versus 0.4%. Now, in the other aspect of the trial, in the carotid endarterectomy trial, the rate of the primary endpoint was lower in the endarterectomy group, but it did not reach statistical significance, really not even close. It was 3.7% versus 5.3%. The p-value was 0.24%. There's a similar breakdown in the components. There were more events in the peri-procedural period, stent versus medical therapy, 9 versus 3, and slightly less in the subsequent 4 years, 0.5% endarterectomy, 1.3% medical, but neither of these differences reached statistical significance. And the authors did something interesting that you don't normally see. They did a tipping point analysis wherein they calculate how many events it would take in each arm to make the trial lose significance. And it's sort of like a fragility index, and it was very low, 3 to 4 events in a 4-year trial of 1,200 patients in the stenting arm, for instance. So my comments on this is big news, and I think it really kind of spells the end of doing carotid endarterectomy for asymptomatic disease. I mean, you had negative trials before this, and now you have no benefit in the CREST-2 randomized controlled trial. The trickier thing, I think, is how to interpret the carotid artery stent comparison. Yes, on paper, it was positive primary endpoint, but the 3.2% absolute risk reduction had a lower bound that was close to 1.1 and a p-value of only 0.02. So this is not a statistically robust difference. Likely because the rate of events is so low in both arms, this could be statistical noise. Again, the tipping point analysis shows that it's just a few events went another way. It would have been statistically not significant. And the components of the primary endpoint are worth thinking about when interpreting the trial, right? If you are randomized to the stent arm, in the stent arm, you have a 1.3% higher rate of stroke or death from the procedure. Those in the medical arm had 0 events. It was 8 versus 0. But then the stent patients enjoy a 1.3% lower absolute risk of an ipsilateral stroke over the coming 4 years. And I think the editorialists did a nice job of laying it out in the accompanying editorial in New England. They write, quote, "Thus, for 100 patients treated with stenting, only approximately 1 per year will benefit by avoiding a stroke at a price of approximately 1 patient having a stroke or dying from the procedure. Over a 4-year period, 95 of 100 patients will have undergone an unnecessary procedure." Now, noted by the authors was the opportunity to do better in the best medical therapy arm of this trial. In CREST-2, in a trial, only 60 to 70% of patients reached their systolic blood pressure target. Less than 80% had reached their LDL target, and only 50% had diabetes controlled to an ideal hemoglobin A1C. So if best medical therapy was better, surely this gap would be even less. And to me, this data closes the chapter on carotid endarterectomy for asymptomatic disease. My feeling is you start medical therapy and you be aggressive with medical therapy, and then you don't do carotid endarterectomy unless symptoms develop. As for stenting, I feel the same way. You start medical therapy, and if symptoms occur, in only a small number of patients, and then for those you can proceed based on anatomy. I also want to say that we have to consider the inclusion and exclusion criteria of this trial. I went back to the protocol paper, which I'll link to. There are 11 anatomic exclusions for the stenting trial. So patients in this trial had amenable lesions, and still, even with perfectly amenable lesions, there was minimal benefit over medical therapy. Finally, this data only applies to centers of excellence in carotid stenting. To be in CREST 2, you had to show expertise in carotid interventions. And so the minimal benefit seen in the trial is surely a best case scenario, and you wouldn't want to apply this data to low volume, willy-nilly carotid stenting centers. All right, next topic is prasugrel versus ticagrelor and the Tuxedo 2 trial presentation at AHA. Now, the situation here is the choice of antiplatelets after PCI and stent. We have aspirin, we have clopidogrel, and then we have the two more potent antiplatelets, prasugrel and ticagrelor. For whatever reason, I don't understand it, I'm not in this area, ticagrelor has become the favorite agent when doctors want a more potent antiplatelet than clopidogrel. And I'm a neutral Martian, and neutral Martians struggle with this because ticagrelor is twice daily, prasugrel is once daily. Ticagrelor has this pesky dyspnea side effect that patients get. It drives them crazy. And ticagrelor beat clopidogrel in the Plato trial, but boy, did that trial have some serious questions raised, and I've covered that. And then came this ISAR React 5 trial, where prasugrel was compared to ticagrelor, and prasugrel shredded ticagrelor. The primary endpoint of death, MI, stroke, was 35% higher in the ticagrelor arm. And major bleeding was even numerically higher in the ticagrelor arm, though not statistically significant. Well, at AHA, Professor Surpal Bangalore presented the Tuxedo 2 trial, and this is ticagrelor versus prasugrel in patients with diabetes and multivessel disease. This was a trial done in India. It was actually a 2x2 factorial design where one of the comparisons was looking at a stent combination, but we're focused on the drug comparison. They had about 900 patients in each arm, and the rate of the primary outcome of death, MI, stroke, or major bleeding was higher in the ticagrelor arm. Again, ticagrelor loses. It was 16.57% versus 14.23%. The actual hazard ratio was 1.22, 95% confidence interval 0.95 to 1.58. Now, this was a non-inferiority design, so this definitely did not make non-inferiority. In a subgroup analysis, patients with diabetes duration greater than 5 years and those with high bleeding risks did better with prasugrel. The major bleeding rates were similar, 8.4 versus 7.2%, and not statistically different. Stent thrombosis, 1.1% with ticagrelor, 0.56% with prasugrel. The authors then, in their discussion, meta-analyzed their data with ISAR React and found a summary statistic of 1.28 in favor of prasugrel. And the Tuxedo 2 authors concluded, quote, combined with the results of ISAR React 5, these findings support the use of prasugrel over ticagrelor. So my comments. I also found a Danish observational study published this month on switching from ticagrelor to prasugrel. Now, this is in the journal Eurointervention, and in 2020, the Danish guidelines changed to recommend prasugrel over ticagrelor in patients with MI. And so the Danish research team therefore looked at whether the shift changed outcomes on a national basis. And of course, you can do this sort of observational study with Danish national health records. And what they found in this study was that prasugrel was associated with a reduced one-year rate of MACE. The adjusted hazard ratio was 0.67 compared to ticagrelor. And there were no significant differences in bleeding. And these findings were also replicated in a propensity score matched population in patients older than age 75 and in non-STEMI patients. Now, this sort of data is not as strong as the ISAR React and Tuxedo trials because it's observational, but it's surely supportive. Tuxedo 2 is not yet published, it's just a presentation, but this is yet more compelling data that supports the ISAR React 5 trial, and to me, if you're going to use a more potent antiplatelet than clopidogrel, then I don't know why you would not use prasugrel first, based on 2 RCTs and a fairly strong observational study. And then I think we should go back and look and see how ticagrelor got such favored status. It might be an interesting thing to think about. All right, finally today, There's another coffee and AF study, but it's a good study. It's interesting. Dr. Greg Marcus and his team at UCF is back at it again, and they have a sort of speciality in dispelling myths and studying important factors in atrial fibrillation. Now, it's sort of a big deal to study coffee because to this day, patients with AFib are told to abstain from coffee. Observational data, however, shows no association of coffee intake with AF, and many of these observational studies actually show that coffee can be protective. No matter, doctors keep telling their patients to stop drinking coffee. It's unbelievable. So the DECAF trial, that's the name of this trial, led by Christopher Wong, published in JAMA, compared consumption of caffeinated coffee to coffee abstinence in patients with atrial fibrillation who were going to have a cardioversion. Now, one of the challenges of this trial, like it was in the alcohol abstinence trials, was recruiting, because you have to find people willing to give up their coffee. That would be hard for me. I wouldn't be volunteering for this trial, no way. But they did find 200 patients with persistent AFib or flutter who were planned for cardioversion who were willing to be in the trial. And those in the coffee group were encouraged to have at least 1 cup of regular coffee per day, whereas those in the control arm were supposed to abstain. The primary endpoint was easy. It was AFib or flutter recurrence after cardioversion. And the results were surprising, actually. In the primary analysis, AFib or aflutter recurrence was less in the coffee consumption arm, 47% versus 64%. This resulted in a 39% lower hazard of recurrence. The hazard ratio was 0.61, with confidence intervals that went 0.42 to 0.89 in a statistically positive p-value. So it looks like, when you look at that Kaplan-Meier curve, it looks like coffee is actually an antiarrhythmic drug. Surely it's better than dronedarone, for instance. A comparable benefit of coffee consumption was observed with AF recurrence only, and there was no significant difference in adverse events. So my comments. Now, of course, I'm not sure we can say coffee is an antiarrhythmic drug, especially since this was an unblinded, open-label trial in 200 patients. But I think what we can say is that coffee consumption does not increase the risk of AFib, and this data is quite similar to the oodles of observational data, and we have enough data. We're done. I think we just can say, stop telling patients with AFib to stop drinking coffee. They can drink their coffee. No, they probably shouldn't drink 5 Red Bulls in a day, but a cup of coffee is fine. And this might seem like a small thing, but I think we need to stop prescribing things that don't need to be prescribed so that patients and doctors alike have more bandwidth to spend that time to reduce things that matter, like alcohol reduction and junk food consumption. So these are really important, but if we're wasting energy on coffee, we have less energy to deal with important things. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time, give us a rating, write us a review. If you have things that you disagree with, listener feedback, send me a note. I love these. It makes me think. And we'll skip next week for Thanksgiving and back first week of December.
You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.